Welcome to the Gyne Awareness Podcast, real talk to understanding gynecologic conditions and care. The goal of this podcast is to bring you clear, evidence-based medical information by experts in the field of gynecology to help empower you in your health journey. Participants on this podcast are healthcare professionals, specialists and advocates in the field of minimally invasive gynecologic surgery. The views and opinions shared in this podcast are those of the speakers and do not necessarily reflect the official policy of AAGL. This content is provided for general educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Listeners should always seek the guidance of a qualified healthcare provider with any questions about their own health. If you are experiencing a medical emergency, call 911 or your local emergency number immediately.
I'm going to turn this a little bit. I have a number of patients that come in and they think surgery is going to be their savior for their pelvic pain. And I often have to share with them that we don't see anything on imaging, I don't feel anything on exam, I'm not certain that their pain is actually gynecologic in origin. We've tried to do a more complete workup, but all they want is surgery. Oftentimes, I'll counsel them that they might not have endometriosis, that I might not be the person to diagnose their pelvic pain. And I just wonder, if you guys have any advice for those types of patients, because often my patients just feel so discouraged after I tell them they're not allowed to cry, that I'm not giving them a terrible chronic inflammatory condition like endometriosis on their surgical diagnosis. So what do you guys say to patients who maybe don't have the diagnosis of endometriosis, but have pretty significant pain? Carol, why don't you go first?
Oh, thank you for this question. This is a really good question. So, we all have these patients in our practice. And I say to my patients in pre-op, right? Nobody wants to be sick. Nobody wants to have endometriosis. But at the same time, you want a reason for your pain, right? And so some of my hardest conversations are when I don't find endometriosis. And that can be hard to understand for sometimes some of my learners or my fellows, this is great, she doesn't have endo. But the weight that carries with it, because their pain is real, and if they don't have a reason for the pain, then where do they turn, right? And so what I think is really important is what Sony and Shanti have really echoed is that building the tribe around your patient and letting them know that you are there for the journey to build the right specialists around them to get them to where they want to be is critical. And so yes, we all are, this panel, we are surgeons. We love to operate. We want nothing more than to operate. But for our patients to understand that if we don't find endometriosis, that is one step closer to figuring out what is going on. So even though sometimes we don't find endo, that's still an answer, and that's still bringing us closer to the right diagnosis. And so building all the right people around that, and that could be pelvic floor physical therapy, that could be pelvic floor injections, that could be, right, all the people that we've been talking about, functional medicine, right, building that team. But you're right, that conversation, and it can feel probably a little conflicting to a patient as well, right? And that, why do I feel sad when I don't have endo? But meeting them where they are and understanding that, I think is really critical in our practice. Shanti, what do you think? It's hard to verbalize this.
Yeah, and you said it really well. One of the things that I think is so hard when we as specialists say to someone, I actually don't think you have endo. Maybe even it's after surgery and they have the cleanest pelvis you've ever seen and you just couldn't find endo. One of the things that's so hard is patients sometimes feel shame. They've had all this pain, they've missed work, or they can't have sex, or what are, any number of things. And they feel like if they could say they had endometriosis, that would be like the reason. And then if they don't, they're almost ashamed. And so we have such a responsibility to encourage them to understand that there are many other things that can cause pain. And I think you just mentioned them, but for example, I've seen patients with such extreme pelvic floor spasms that they feel deep pain throughout the bladder and lower pelvis. And what happens if you release some of that with Botox or trigger point injections or therapy or self-therapy with a special kind of device called a wand that you can use to treat your own muscles, and they begin to feel some relief. But if we think that everything is going to be cured by, and I think you said this, Angela, is that if everything will be cured by surgery, that isn't always the case. And especially if you've had pain for years, you've developed all these counter mechanisms to deal with the pain. And sometimes you're deconditioned physically, or you have spasms in your pelvic floor because it's the gatekeeper to keep anything away from this terrible pain. So, but back to what else do we do? I think you listed it really well, Cara. And all of those alternative modalities and other explorations for bowel disease or bladder disease are really become even more important.
Yeah.
So, Sonia, I'll hand it over to you next. Yeah.
No, I think this is a wonderful topic because it's a very challenging issue when we see these patients. And I think for me, it starts right from the beginning, just like for all of you. It's about education. What is pain? Pain is that protective response against a threat. And, a period in some patients, we don't know why, even without endometriosis, can trigger pain. And so there are a lot of factors that may lead to that pain, and unwinding that pain can be quite difficult. So a line I use, and I don't know what you all think of this, but I can cut out endometriosis, but I can't necessarily cut out pain. And so, we work on that, but at the same time, making that relationship that I'm not going to abandon you. This comes back to Shanti's point of that shame, is that, you know what? We're going to the OR. And you may or may not have endometriosis because we haven't had all the stuff you described, Angela. We don't have the ultrasound findings, anything else that can tell me you have deep endometriosis. But you know what? After this, I've got a plan for you still. I've got a plan that'll involve physio, it'll involve pain education, it'll involve looking at getting those hip x-rays done. Like I told you, I've had to learn how to become a sports medicine person. At the same time, pelvic floor. So there's so many different things. But, 20 years later in practice, I've had 18-year-olds who are now 38 years old, and I can tell people with confidence when I first meet them, you know what? We will get you better. Whether it may look different for everybody, but we will work with you to get you to a point where you're back to working, functioning, and, doing what you want to do if you want to be on this journey with us. Not everybody does, but at the end of the day, we're there to work with you. And it may mean surgery, it may mean medical therapy, it may mean just listening. And that to me has been the most satisfying part of my whole practice. I really enjoy working with my patients with chronic pain because there is things I can offer and follow up on.
Now I know why you have such a long queue.
It's true. It's true. I mean, I love this idea of pre-operative expectations, right? Setting those expectations up front about what things are going to look like after. So, we talked about the person who maybe we don't find endo on. What sort of pre-operative expectations do you all set for patients who do have endometriosis when you find it? What's going to happen to them afterwards? Shanti, why don't you start?
Well, that's a really good question. And there's a lot of controversy about it, right? A lot of my patients absolutely do not want to take hormonal suppression after surgery. And in fact, I think there's not a lot of data that says they have to. If they have terrible side effects and if you've really adequately excised the disease, I'm someone who doesn't believe that most disease is caused by this thing called retrograde menstruation, where it leaves the uterus and goes out into the body instead of out through the vagina. So I think that some may be, certainly, but I think that if we truly excise it, we still are going to see patients continue to do well, and most of them are not going to have repeat surgeries. So I don't insist that everyone use a hormonal treatment. Many need contraception anyway. And so if they want to be on a hormonal treatment or they want me to slip in a levonorgestrel IUD while they're asleep, that sounds like a great idea to me, then they don't have to feel it going in during the clinic. So I do offer that to most patients who aren't trying to get pregnant right away and want to keep their uterus. I think that's one really tolerable option, and it's about 20% of the systemic hormonal load as a birth control pill. The other thing that I think is incredibly important is diet. And what this is going to branch out into another hot topic, but I do believe that our gut microbiome, so this means all the bacteria that live in our gut, play a role in our health and play a role with endometriosis. And let me give just one example. When we have a certain bacteria in our gut that is kind of maybe one of the bad ones, so we call it dysbiosis, that certain kinds of this bacteria in the colon can release an enzyme that makes estrogen that would normally be excreted reabsorbed, raising estrogen levels that in theory could perpetuate the potential endometriosis or ovarian disease, which is another topic one of you maybe want to answer. And so really supporting your gut health, and that really means a balanced diet with at least 6 servings of fruits and vegetables a day, and protein and water that's not Coca-Cola or coffee, and and really supporting your health, right? So cooking your own foods, not having processed foods, and the reason for that is not hokey. It's really, we have this load of 90% of the cells of our body are bacterial that we want to keep in a healthy balance. And I do believe, really, not just for endo, but any disease process, we need to support that part of our gut health to support our recovery and reconditioning to well-being following endosurgery. Okay, I should step off the enough of my
Cara, I'd love
mouth
for
for a
you to
minute.
add to that. I 100% agree. You're taking care of your whole body in a more holistic way to decrease inflammation. Absolutely, right? Makes you feel better. Cara, what do you share with patients?
Yeah, I mean, I think you're exactly right. I say this all the time, and our body doesn't work in silos, right? Like everything overlaps with everything. So I think that's really important to remember. And you're right, this topic of post-operative hormonal suppression, it comes up a lot. And I think, again, I go back to every patient has such a unique journey and priorities and other comorbidities, right? So I like to think about also that many patients have overlapping adenomyosis, which is when the lining of the uterus can implant into the muscle wall of the uterus and cause a lot of dysmenorrhea or painful periods. And so if I have a patient that we preserve the uterus and they're not looking for pregnancy soon, and we do full excision, sometimes putting in that progestin IUD or some type of hormonal suppression can help the adenomyosis component of things. Or if somebody has a lot of central sensitization, right? So if somebody, again, the delay of diagnosis is 7 to 10 years, that is a huge amount of time for your body to remodel with the neuropathic pathways, pelvic floor spasm, and central sensitization. So even if we do the most perfect excision surgery, beauty at the end, if their pelvic floor is still spasming and they have remodeled, neuropathic pathways, sometimes stopping periods, not forever, but for a couple of months while we reset the system can be helpful. And so I think number one, at Sony is so good at this. I want to be your patient, truly, is education, right? I mean, I don't want to end it, but I'd love to be your patient in the way that you counsel, in that educating your patient, pros, cons. There is no right or wrong. I sometimes have patients apologize to me. I'm so sorry, Dr. King. I don't want hormonal suppression. I'm so sorry. Dude, please do not apologize to me. There is no pressure. Like, our job is truly to educate, give you all of the different options, and then to tailor the treatment based on where you are at this moment. And we understand that your situation may change in 3, 6, 12 months, and we're here for it. We're here to flex with you. And so I go back again to Shanti's emotion of shame. Like, we are here to meet you where you are, wherever you are at that moment, to educate you and to help you through that process. So there's no, again, kind of cookie cutter approach. There's just so much counseling that goes into every single facet of this. Sony, please blow me away with your education, please.
Well, so I think just like orthopedic surgery and other surgeries, we do talk about prehab and rehab as well. So before you walk into a surgery in our situation, because we do have some what of a wait time, uh, down regulating that pain response is important. Getting control, getting the physio started, and in some cases, treating the period pain early is important. You'll do better. Eating well, making sure we get enough protein in, and being ready for the surgery. So then you go through the surgery, and then you want to rehab because you still now have to recover. And if people have come in with tons of pain and you go straight to surgery, that post-operative experience is going to be very difficult, especially on the bladder, the bowels, and the other health, especially if patients are already on painkillers such as narcotics. So we really try to unwind a lot of the pain before we go forward. And I think There's a couple of things I do want to add though, because the fertility journey is a little bit different. And so if you have something called endometrioma, Shanti said one of us would take it. There is good evidence that if you clean out the cyst or the endometrioma because somebody wants to get pregnant, being on hormone therapy after that does reduce the risk of recurrence of an ovarian endometrioma. So many of our patients who are ready for the fertility journey may go on a progestin. We have a couple of more options than you folks do down south until that surgery time. Until the IVF time or fertility treatment time. And so that may be a very important discussion with the fertility person. Final thing, I just wanted to go, I think everybody here agrees, we're never going to ask you to force you to go on anything you don't want to be on. We're never going to say you have to take a medication before to make sure you have endometriosis. I think we all agree that it's your choice, and we'll support you through that choice. Your value system, your experience are individualized, and we'll walk through and along with you on this journey. But at the same time, we'll give you our experience and our understanding of where we think you should go. But we would never ask somebody to do something that they don't want to do before or after surgery.
I mean, I love all of your responses because really it's all just about education. It's about supporting each and every patient on their individual journey wherever they are, whether they are looking for fertility in their future, whether they're saying, I'm done with that part of my life and I really just need to get my pain under control. Wherever they are, we can meet them with observation, with medications, with surgery. I think a lot of patients, though, listening might say, I'm hearing all these different treatment options. Really, what are my long-term consequences with endometriosis? I get this diagnosis. What does that really mean for my overall health moving forward? Who wants to take this one?
Here, I
Dr.
can
King,
start.
Sony.
Maybe
Yeah.
I'll start this time because then I don't have to go after these brilliant people and they can finish. Um, right now, I remember doing a presentation that looks at the whole lifespan of somebody with endometriosis. So in adolescence, getting through school, getting through, that first job, supporting them. So that's often a focus of improving quality of life and pain. Later on, wanting to get pregnant, so supporting through patients through fertility journey. Once patients are pregnant, we know that patients with endometriosis, especially the severe forms, may need a little bit more attention during pregnancy. We won't get into it too much, but I think that people need to know if you've had endometriosis surgery or have endometriosis and you're pregnant. And then all the way to menopause as well, the journey doesn't stop because as a patient approaches menopause, they have to deal with all the perimenopausal symptoms, menopausal symptoms, and might still have pain and even afterwards. So it really is a lifelong journey. And I think that the consequences are really individualized if there are consequences. And it really is dependent on the type of disease, what the patient's been treated with, and where they're going with their life goals. There's a lot more to it, but now I'm going to hand off the baton. I don't have to be the last person.
Shanti, anything to add?
Okay. So the concept that you just brought up, Sony, about the different stages of life is really so key. We can talk about two things. We can talk about the impact, the social impact on one's life of endometriosis, and that can be devastating. And we can also talk about bowel obstruction and emergency surgery or pneumothorax and going to the ER and extreme things. But if you think about a teenager with debilitating pain, not being able to play a sport, missing school, not doing as well in school, that trickles through their life, right? Then they're limited. They might not have as much opportunity socially. They might not have as much opportunity in terms of schooling and who they want to become. It affects who they are as an individual, right? And so this impact of living with chronic pain as a young person sets the tone as they move forward in their lives. Then you take relationships. Take someone who is in their 20s and 30s who is in a relationship and in say maybe a marriage or just a partnership, and they really can't have sex. They can't have sex because it's so painful. That is going to impact the relationship. And impact their ability to stay in a relationship sometimes, or impact the dynamic where one's always a care provider and one's always feeling like an invalid. So these are some of the social impacts, right? So we have physical impacts that can be devastating, but we have social ones that can be devastating too. Okay, you're on, Cara.
That was so beautifully put from both of you. I don't have a lot to add. I'll be honest. That was beautiful. I think the take home messages is that you're never too young or too old to have endo. It truly is a lifelong chronic disease. And I think the other take home message is trust your own experience, trust your symptoms, know that that you know your body the best. And also what I'm hearing you guys say is pull in the people close to you into these visits, into these appointments, into the journey, right? So sometimes it can be nice to bring your partner or your friend or whoever is your support person to these visits to help fill in the gaps and to help listen to the counseling and help take notes, right? Because there's a lot that goes into this. And so validating yourself, finding the right provider to help with the entire continuum of care is really critical. And then also, I know this may feel vulnerable, but pulling in your support person or someone important to you to help you through this, I think is also a critical part of the journey. Angela, what do you think? Whew.
You guys all, I mean, I like Cara sort of reiterated before, I think all of your focus on education for patients and advocacy and understanding what this could look like for them at all their different life points is so important. I really want to thank all of you guys for being on today. I'd love to end with any final piece of advice you have for our patients listening. Cara, start us off.
Patient advice. Okay, let me think about this for a moment. I think I'm going to echo again what I've said in that trust yourself. This word of gaslighting keeps coming up, and I don't want any patient to think that what their symptoms or what they're feeling is not real, because it is. And the take home message is find a provider who's listening and is there for the journey with you. And if they're not, then find somebody else. And again, utilize AAGL to whatever we could help you with, in that we have providers who are highly trained in this. And so we are here to help support you at any point in your journey as well.
Oh, thank you, Cara. Shanti, what do you think? What advice would you give a patient?
Well, I would give Cara's advice. I think it's great. And I might add to it, not to normalize pain. That we as a culture normalize painful periods, like, oh, periods are painful. Yeah, just, you got to take some ibuprofen and go to school, and here you can take 7 more. And really, that's not normal. And we really need to back away from normalizing what is a debilitating condition.
I 100% agree, Shanti. Sony.
So
And
I'm
is
going to
that
try to end off with a positive note in that when I see a patient when they're really young and they come to me and they get a diagnosis of endometriosis or are worried, they're scared. They're scared about their future ability to have children if that's what they want to do. They're worried that there's something more dangerous going on. And I always reassure them and I said, first of all, you're in the right place. We've got the right team. And most people, if you want to get pregnant, most people with endometriosis can get pregnant. We have to remind people that in these cases that is hope and there is good outcomes. Otherwise, we wouldn't do this. And so treating each patient and getting them with the right providers and the right teams, we will see a positive outcome. And so I tell my younger patients, because we all have followed our patients through, that if you want to stick on this journey, I'm by your side and I'm aiming for you to have the best life possible. As Shanti pointed out, the full potential of your life, and I'm there to work with you. That is why I did this job. That's why we all did this job. And we're going to walk through this journey with you, and it's going to be a great ending. So I think I want to leave it with a positive. Most of my patients, I wouldn't do what I do if they weren't doing as well as they are after years of care.
So beautiful. Thank you for saying that.
really beautifully said? And I'm just going to add, keep asking questions, keep letting your doctors know what you need. Ask how many surgeries they've done, ask what they know about endometriosis, ask who else you can see. Anybody who's on this panel would say, if you're not sure, here's my 10 friends that do this too, and you should go see them around the country, because we want you to get the best care you can. We want you to find the best doctor you can that is treating you for what you need at your point. And I've really just, I'm so thrilled to be on this call with you and really doing this very advocating podcast for our patients out there who are suffering with pelvic pain and suffering with endometriosis. Thank you all so much for being here on the Gyne Awareness Podcast. The AGL is, such an amazing organization that we're all lucky to be a part of. And I know that we're really excited to bring all this information out to our patients. So thank you so much.
Thank you.
Thank you, Angela. Thank you for listening, everyone.
It's a great honor to be with all of you, and a great honor to help spread the word. I think as anyone listening could tell, we so completely believe in this work, and as Sony pointed out, that we wouldn't do it if we didn't see that we could make a difference, right? So we hope that we can bring some of that to all of you.
And thank you to my folks here, that you guys are amazing and inspiring, that it really tells us we have many great care providers who are walking alongside our patients, and the future is bright and getting better every day. Thank you all.
Yeah.
Thank you.
Thank you.
Thank you for listening today. We hope you enjoyed this podcast. To listen to other podcast sessions, visit us at gyneawareness.com. You can also follow or subscribe to the Gyne Awareness Podcast on Spotify or Apple Music.